This is the closest thing we get to remission of PCOS. This is
Wow.
a syndrome that affects you for your whole life. And this is the closest we can get to just causing it to go into remission. Anywhere from 75 to 90% of women who don't ovulate on their own will start ovulating more regularly with a wedge resection. And even in that set of women who don't ovulate regularly, post-wedge, because that's still 10 to 25% of women, they do end up having much more sensitive ovaries.
Welcome back to the Truth and Fertility podcast. I'm Haley Yeager. Today I'm sitting down with Dr. Erica Kreller. She is an OBGYN. She is also a surgeon trained in NaProTechnology, which is short for Natural Procreative Technology. She's also my old boss, and I love her to death. And she delivered my third baby. So,
There's a lot of different ways.
There's a lot of different ways.
We know each other.
But I am so grateful for your time to be on the podcast today, because we're going to be specifically talking about PCOS, polycystic ovarian syndrome, and then surgical treatment for PCOS, being the ovarian wedge resection, which is very specific to NaProTechnology, and not something I would assume many people have heard about before. So I just want to pick your brain about that. But before we do, Dr. Kreller, why don't you go ahead, maybe add anything you'd like to add about just yourself and anything else?
So I was trained, I did my residency in the Navy, and I went to the University of Southern California. So kind of in a very secular world, just trying to find my way as a Catholic physician. And then really came to the realization that I kind of needed to switch off of prescribing contraception. And when I did that, I realized I didn't have any tools left in my toolbox, because that's kind of all you do in gynecology and mainstream gynecology. So that was what led me to do the fellowship at the St. Paul VI Institute in Omaha, where I spent a year there doing, advanced surgical and medical NaProTechnology, and then made it out to Arizona, where we've been just having a great time for the last almost 7 years now, which is crazy to me.
Have you been here 7 years?
Yeah, isn't that insane?
Okay.
September, it'll be 7 years. So almost there. Yeah.
Yeah.
That's wild. I mean, I can't
flies.
believe that I see these little 6-year-old kids running around. I was like, I delivered you. That's so amazing. It's so bananas. I just can't wrap my head around it. But you know what's interesting about, and then maybe you're going to ask, maybe you're going to talk about this, because you say, PC or wedge resection is kind of unique to the NaPro world. But it's really interesting because this was kind of a standard of care, or it was like a surgery that was done fairly frequently. The surgery is almost archaic. Like, the guys who invented this surgery were the ones who really characterized PCOS initially, Stein and Leventhal. It was actually called Stein-Leventhal syndrome. And they, and I'd have to go back and read again, because I don't know how they realized that these women had really big ovaries, because they didn't have ultrasound at the time. They just realized that, these women who had, ovulation that was really irregular, signs of high male type hormone levels, lots of facial hair growth or acne, or various different, other things. And they realized that these women who had these things that went together also had these big ovaries. So they must have done surgery at some point and just opened people up randomly, because you couldn't see it on, they didn't have ultrasound at the time. But so they said, well, what happens if we just resize them? What if we just make them normal? And so the wedge resection was actually invented back in the 1930s and 40s, way back. And then it kind of evolved as we went forward. But the thing is, the thing that's interesting about it is, so there were problems with it, because, surgery was a big deal, right? Surgery was a huge deal. You opened somebody up, you gave them this big scar, this infection risk was really high, all of this kind of stuff. So we're always looking for, how do we avoid surgery? How do we avoid surgery? How do we avoid surgery? So we get to the 60s and 70s, and then you get the advent of medications that can make people ovulate, like Clomid and stuff like that. And so people are like, well, we can help these women get pregnant without doing surgery and taking all these risks. So then it starts to be done a little bit less frequently. And then in the 80s and 90s, even less frequently, because again, then you get the advent of IVF and other medications to help people ovulate who have PCOS, but they're not necessarily all that effective. And the problem, and then you get into the 90s and surgery starts to get really like based in laparoscopy. So laparoscopy comes where you're doing like little surgery, or sorry, keyhole surgery, doing surgery through these tiny incisions. And when you do that, like a wedge resection is actually really hard to do laparoscopically. So then all of a sudden it's like, well, if you're going to do this surgery, you've got to open them up, and we don't really want to do that anymore. So then it starts to really fall by the wayside. And when it falls by the wayside, it's funny, like it takes you train a couple generations of surgeons, and then if you're not doing them, then we assume that it was just this archaic surgery that stopped being done. So when I was trained, it was like, yeah. This is this historic surgery that nobody did, or like that they did in the past, and for some reason they stopped doing it, and so it's not worth my time. But then you start to realize that, and the other issue was like, so surgery is a big deal, but the other issue was scarring on the ovaries. So sometimes you create so much scar in how they close the ovaries that they couldn't ovulate. It was like, okay, I can do all the hormonal things, but I can't actually release that egg. And so then,
Besides the point, basically.
yeah, exactly. So it was a really effective surgery, but then sometimes you got so much scarring that you didn't ovulate at all. So then we get into like the NaPro and Dr. Leonard, Dr. Hilders, who starts thinking about, like how do we, like maybe these women just need to have this correction done. And maybe we can actually attack the problem of, minimizing the risk with surgery and decreasing the risk of scarring. And so like maybe we actually like, this is a super effective surgery, so maybe we just fix the problems with it. So that's kind of like where we came into it. But as a trainee, I was just kind of like, I knew about ovarian drilling. But I thought that like ovarian wedge resection was just like an historic surgery. I mean, it is, but it's also something that can be done like currently with current techniques to really minimize risks and stuff.
Yeah, yeah. I knew it was an older surgery, but I didn't know it went back to like the 30s and 40s.
I think so. I mean, I looked this up at some point, but I'm pretty sure it goes back to like the invention of Stein-Leventhal syndrome, which is
Okay.
like that's like
Which is
1930s and 40s,
PCOS.
which is PCOS.
Right. Okay. Yeah. And so uh, there's so many questions in my head, but I don't want to get too ahead of myself because the first thing I want to do before we go any further is can you just give a very brief intro into what PCOS is? Because
PCOS is, yeah.
if a woman is going or is looking into the surgery and looking into, having that done, what exactly is PCOS? Why would you have enlarged ovaries with PCOS?
Right. Well, I mean, it's interesting. So PCOS is polycystic ovary syndrome. PCOS, polycystic ovary syndrome. And the interesting thing about medicine is that like when we call something a syndrome, we don't really know the cause. It's just that there are things like when we say something is a disease, it's like, okay, it's this set of symptoms that's caused by this thing. And and that's what you get. So when you have PCOS, you have these this grouping of women who experience particular symptoms in particular collections, like in particular ways, um, and they express certain things, but we don't necessarily know the root cause of it, and we don't know if everybody has the same cause. And there's been a lot of research on PCOS and the different ways that it appears. Like there are lots of different types. I think there are 5 types of PCOS. But in general, to make the broad diagnosis of PCOS, you have to have like the most widely accepted diagnostic criteria there are 3 criteria, and you have to meet 2 of the 3. And if you meet 2 of the 3, then you're considered to have PCOS, as long as it's not being caused by something else. And that's the most important thing about PCOS, um, that a lot of people don't know, is that you can't have another explanation for the symptoms. So the three sets of symptoms are irregular menses. So generally long cycles, usually like traditionally over 35-day cycles, but even 32 to 35-day cycles are suggestive of PCOS. And then the second is either signs of high male type hormone levels, which are called androgens. So this is like extra hair growth, like under your chin, kind of sides of your face, around the nipples, between the breasts sometimes, under the belly button, like stuff like that. Places where you would are just less common to see on women. Acne, especially into adulthood, not necessarily as a teenager, but into adulthood. And then the third is polycystic ovaries, which I draw this picture. I don't know. I'm sure I've drawn this picture for you before, but where, it's not, so it's kind of a misnomer. We think of cysts on the ovaries as being these big fluid collections, and they are. But in polycystic ovaries, it's not actually that we're worried about. It's everybody's got these little tiny follicles that are sitting there waiting to be recruited. And your body recruits a new set each cycle. And so you got all these little follicles that are sitting there and getting recruited, and then one of them will grow and kind of beat out all the other ones, and all the other ones die off, and then the next cycle you get a new set. Well, in PCOS, you just see more of those little antral follicles. And so, and they tend to be in a different collection. Like they tend to be not scattered randomly throughout the ovary, but collected around the outside. And then, traditionally in polycystic ovaries, sorry, my 2-year-old's over here, or
There are plenty of
3-year-old
babies.
actually.
There are plenty of babies that come on the podcast.
I know.
So he's welcome to stay.
So in the third, they tend to be bigger. And there's lots of different definitions, and there's lots of different conversations about how we should define polycystic ovaries. There's lots of different thoughts as to how we should define this. Is it based mostly on size? Is it based mostly on antral follicle count? Is it a combination of the two? But so there's different conversations about that. Generally speaking, if you're estimating the volume of an ovary from a transvaginal ultrasound, you can't really do it from an abdominal ultrasound. The volume of a classically polycystic ovary is going to be 15 milliliters or larger. And the volume of a normal ovary should be less than 10 milliliters. So the thing is that, the really important thing is that a lot of women will express all of these things, but they haven't necessarily had the other things ruled out. Because this is a mimicker of a lot of there are a lot of conditions that mimic PCOS.
Yeah, I was going to ask, what are some of the other things that it could be?
So, well, I mean, so irregular cycles, take that for a minute. You could have like a minor thyroid condition, and or even a major thyroid, like autoimmune thyroiditis, and that can throw off your cycles pretty significantly. More rare and more worrisome are condition, well, not necessarily worrisome, but there's something called congenital adrenal hyperplasia, and congenital adrenal hyperplasia mimics PCOS exactly, but it's caused by a lack of a particular enzyme, and so you can't convert hormones in the normal way. It's something you're born with. And then actually, I don't know that you know this about me, but there is another mimicker. It's called Cushing's disease or Cushing's syndrome, where you have too much cortisol, and it manifests in a lot of the same ways: irregular cycles, high androgens, not necessarily polycystic appearing ovaries, but sometimes yes. And it often gets missed, but it's a much more serious condition where you have too much cortisol in your system. And it's hard because women with PCOS tend to have more cortisol anyway. That's a common cause of high cortisol levels. But if the cause is something else that's causing Cushing's, it's going to look like PCOS. And when I was a young 20-something-year-old, I actually got diagnosed with PCOS, but it was actually Cushing's disease. So it was missed for years.
Wow.
And then I ended up having a pituitary tumor and had to get that removed. It was wild.
Oh
So
my
I
gosh.
try not to miss that diagnosis myself. But so it's important that the important things, and you don't have to, I mean, it's not everybody needs a workup for Cushing's syndrome, but the basic stuff, like checking prolactin levels. High prolactin levels can throw off your cycles and make them irregular. Other problems like low weight, if you don't have a lot of body fat, that can cause your cycle to be really irregular. And actually, women who have that particular problem can also have polycystic appearing ovaries, which is kind of crazy. And so there are a lot of mimickers. So you have to rule out the other stuff. And then if you've ruled it all out, either clinically or with labs or whatever, then you're left with PCOS. And PCOS is the most common cause of all of those things, but you still have to make sure you don't miss anything else. So
Yeah, sure. So at what point then, because there are other ways, of course, of managing PCOS, whether it be diet, medication, whatnot. So at what point would you say, okay, going from managing in those ways to you need surgery, we need to do
right.
the ovarian wedge resection? Like where's that point?
Um, well, I mean, it really depends on the person because and how much what do they feel about it and the success of what you're having. So like if somebody's able to manage it, like they can be really strict about their diet, they're making sure they're getting good muscle building exercise, they maybe take a supplement like myoinositol and they feel okay on it, and they're ovulating regularly and they're feeling pretty good and they're like, yep, I could do this forever, then great, then that's what we do, because that, that's avoiding surgery is always, if we can avoid surgery, then that's a good thing and get the same results. That's great. Um, it comes into play. Well, I mean, there's different, like, are you trying to achieve pregnancy? Are you trying to just maintain regular cycles? Like a lot of women, hey, I don't want to be on birth control to like mask my cycles and just like, and the reason part of the birth control is prescribed for two reasons. One is that like it actually, it takes over their cycle. So they get a period when they wouldn't, or they get a withdrawal bleed anyway. But there's also an issue, which is that you can end up, it does end up raising this particular protein called sex hormone binding globulin. And that actually does decrease some of the, like the androgenic stuff, like your acne and stuff. There are other things that do that, but so there are women who are like, I don't want to be on birth control. I really feel not so great on these supplements, or I don't want to take these for the rest of my life. Or they're not working. Like I'm still not having a cycle. Especially if somebody's trying to achieve pregnancy, if we're using ovulation induction medications like letrozole, Clomid, and it's not working. Those are the things that kind of really push us down. But I've had other people who are like, yeah, I just don't want to be on supplements the rest of my life. I want to cycle normally on my own. And those are also people who can benefit from it.
Yeah. Well,
Most important thing sorry, go ahead.
sure. No, you keep going.
I mean, the most important thing in figuring out if somebody's a candidate for this is actually figuring out, like, do you have a high ovarian volume? Would you benefit from the loss of the extra ovary? Because there are women with PCOS who wouldn't necessarily benefit. And then you end up getting pushed into like perimenopause, and you don't want to end up there if we take out part of your ovary. So that's that's a really important thing, is figuring out who's going to benefit and what's the best way to figure out who's going to benefit. In NaPro, especially among the Society of Procreative Surgeons, which is all the surgeons who've gone through the institute and done the fellowship, these are conversations about like, who's the right person for this and how do we decide, so we make sure that everybody who could benefit and wants to do it gets it offered, but the people who aren't benefiting, we're not doing surgery that would cause them harm, because
Yeah.
it can go both ways.
Yeah. Is that okay? You're talking about cutting out a piece of the ovary, right? Can you kind of discuss what this surgery actually looks like? Because,
Right.
and also too, the other question in my head, maybe you can answer these at the same time, what's actually going on in the ovarian wedge resection. But then also, you mentioned how some women may not benefit from this because some women maybe don't have enlarged ovaries with PCOS. So can you talk a little bit about that too? And that, okay, how do you make sure that they have enlarged ovaries
Right.
and actually need the surgery? But then also by talking about like, okay, you're actually cutting out a part of the ovary. So kind of what
Right.
does that look like?
So I mean, it's hard when you're figuring out who would benefit. Well, and the question is like, why? Why do you benefit? What's going on here? And we think that there's this abnormal conversation that's happening where your ovaries, and we don't know where the conversation starts, but your ovaries are producing too much of the male type hormones, testosterone, things like that. And that's actually like influencing how your liver functions and produces these hormones that are supposed to bind up extra androgens like testosterone. It's lowering those levels, and then and then that's feeding back and and stimulating the ovaries to produce more androgens. So we're stopping this cycle, this abnormal conversation that's happening between the ovaries and the liver. And so how we do that is we remove the extra portion of the ovary. So the ovaries are enlarged. We're trying to make them normal sized again. We're not trying to make them small. We're just trying to make them normal size so that they then, because what we've observed is when we do that, they function normally, and they ovulate more easily, and the androgen levels drop, and people are able to achieve pregnancy more easily. So what we actually do is we go in. Yeah, I'm sorry. I have videos. I couldn't pull one like not. I don't have it ready for you,
No, that's okay.
um,
That's all right.
but we basically you go in and you measure the ovary carefully, using various we know how long certain instruments are, so we measure the ovary. This is in surgery, and then we mark out how much would be left if we were to leave a normal portion of ovary. We mark all that out, and then we remove the extra. And then the most important part of it in the NaPro context is actually closing it, because if you so you've got these two, like a wedge resection, an ovary is like this big oval, looks kind of like a football, a little more rounded at the end than that, maybe like more like an Easter egg, or an egg. And the wedge is actually removing the portion from the middle of it, because we want to be able to very easily close and make a fairly normal appearing ovary afterward. So then if you just close it, so you've got these two parts of the ovary, if you just close it like this, you've got all these edges that are really raw. And in your body, when you're surgically closing things, if there are raw edges, they heal to other raw edges and then they scar. So you get all this like scarring created around the ovary, around where you took out the wedge portion. So in NaPro, what we do is we close the inner part to hold it together, and then we actually tuck all those edges in, so that only smooth surfaces are exposed. And then there's a lot less scarring. We've been able to reduce the scarring by about 90%. Um,
Wow.
so how do you figure out who's the candidate for that, or like who's got the right size ovaries? Well, I mean, sometimes it's really easy. You do an ultrasound, somebody's got like 20 centimeter ovaries, even when their ovaries are quiet. Like, you have to be careful, because if you're measuring ovaries while somebody's in an ovulatory cycle, it's going to measure bigger because you have a follicle that's developing. So we try to measure them at the beginning of a cycle when everything's really quiet. So that, that's certainly size criteria. Generally speaking, and every NaPro surgeon's a little bit different on this. It's hard because the measurement by ultrasound is not the be all end all of everything. Sometimes the measurements are really accurate. Sometimes you're like, gosh, everything looks, but your ovaries are not, like, they're really long, but they're not, the volume isn't there. And maybe my ultrasonographer didn't quite measure that right. And so I've had patients where we kind of like talked about it, and we're like, hey, we're kind of on the edge of this, but I think, we're going in to look for endo or whatever you're struggling to achieve pregnancy. If they look polycystic, then maybe we should plan to do this. And we talk about risks and benefits. The other thing that we're starting to do, or that I'm starting to do, and that Society of Procreative Surgeons were kind of talking over, we'll probably be studying this in the next few years, is looking at your anti-Mullerian hormone level, which is a hormone that's produced by all the little antral follicles that are sitting there waiting. And so in PCOS, part of the thing is you've got a lot of ovarian volume, a lot of little antral follicles sitting in there. And so generally speaking, women with PCOS have high AMH. But the question is, like, how high is high? What do we do with this? So I use it in concert with the measurement of the ovaries. Like, I look at the AMH levels, I look at the ovaries. If your AMH is like, normal AMH is usually like a little, like between 2 and 3. And then if you're over 4 or 5, probably. If you're over 10, almost certainly. I've had, like, I think the highest I've seen is like 20. It's like, nope, yeah, that you definitely have PCOS. Um, so that's kind of an emerging question, because when they did this commonly, they didn't use AMH. Like, when this was a widespread surgery, they didn't use AMH. That wasn't a known hormone to be measured. And
Yeah.
so that's what we're trying to figure out. Like, how do we bring this into the modern sphere? How do we use the techniques that we have right now but sometimes I'll have somebody who has all the markers of PCOS and their ovaries are maybe like kind of in the larger end of normal. And then I'll do an AMH level and it's like 2. It's like, okay, you're not going to bet. Like, I don't think it's worth the risk. of taking you to surgery. And we talk about how do we manage things else otherwise. So
Yeah. So what I'm hearing is that there are sometimes when you're working with a patient who has PCOS and they just plainly are not a candidate for this surgery, and the
or
best
it
thing
would
for
just not be
them.
worth the risk, where
Okay.
it's like, I don't think, because this is not like, say when we're looking for endometriosis, there's not a lot of risk to doing that. We go in,
Mm,
the surgery itself is very low risk. You do have to undergo general anesthesia, but overall the recovery is quick. Surgery's low risk. We find it so often that like going to look is not a big deal. PCOS is different, right? It's like, okay, could I cause you harm if I do this and it's not the right thing to do? Yeah, absolutely.
yeah.
And
Can you
so
talk a
we
little
want to
bit
be really
about
careful about that.
what is that harm? Like, what are the risks that are
Well, so the harm is
there?
that, like, if you don't truly, like, if all of these symptoms aren't in your case caused by an excess of ovarian tissue, then taking out ovarian tissue will cause you to, like, so we take out some of your eggs and some of your, that all comes out with the ovarian tissue. And so then you can get pushed into, like I was mentioning before, like into perimenopause. So then you're like not ovulating well because you don't have enough eggs. Like in the worst cases, you could throw somebody into all the way to menopause. Like we're really careful with that. We don't usually find that to be the case.
Yeah.
I've never had that happen to somebody, but it's something that we want to be really, because once you take it, you can't grow it back.
Yeah.
And
Yeah.
so that's why you have to be pretty careful about it.
Okay. Well, and so on that note, especially discussing the risks of this surgery, I want to talk about, a patient who is looking to do this because they've been struggling with infertility
Hmm.
and they, despite the medication, despite the management, despite Clomid, despite all of those things, they're still not getting pregnant. I would say,
Hmm.
okay, yeah, maybe the risk is worth going through that surgery just for the sake of trying to get pregnant.
Right.
Let's talk about then for the woman who's either single or maybe she's a teenager, late teen, and is having really bad symptoms of
PCOS type
PCOS.
symptoms. Yeah.
Yeah. What would you say about that, of doing the surgery on someone who's not necessarily doing it for the sake of infertility, or maybe may
Well,
have
yeah. And so,
infertility down the road, but you just don't know? What are your
right.
thoughts on that?
Right. So it's just certainly something that you could, that I've done. Like again, some women don't don't necessarily, like, they're not aiming to achieve pregnancy right now, or they even feel called to the religious life and they're not aiming to ever achieve pregnancy. But they are wanting to just like cycle without needing to take medicines their whole life, or cycle on their own. I think that's a set of women that really gets neglected in our current gynecological paradigm. Like when I was training, it was like, well, if you have PCOS, you're either actively trying to achieve pregnancy or you're on birth control. Like those are the options. And it's like, no, some people just want to have a period. And the funniest thing is, like, traditionally we as women are like, oh man, it's my period, right? You get one of these PCOS women women who suffer from PCOS, after you do their wedge resection, they come in and they're like, I have a period. Like they're so excited. And it's so funny. It's great. I mean, because they're like, okay, my body's functioning the way that it's supposed to. So
Exactly.
it's not something that's just for women who are suffering from infertility. It's definitely something that is an option. I have done it and any kind of surgery in teenagers, you got to be really careful to make sure they understand the risks and the benefits. It's pretty uncommon, but I've had some patients where it's like, this is clearly an issue. The other thing with teenagers you got to be really careful of is sometimes their cycles are really just irregular because the communication between their hypothalamus and their brain and their pituitary and their ovaries is just really immature. So maybe
Hmm.
they have irregular cycles just because that hasn't matured yet. And
How
and
long does
so
that normally take,
it can
to
take
where you would be
years.
like,
And that's the thing. It can
what are we
take
talking?
like 3, 4, 5 years.
Okay.
Not always, and then sometimes you're like, well, there is this, and you have to be careful, like AMH and stuff. That's not really teased out in teenagers because our AMH falls as we get older.
Yeah.
And
Yeah.
so teenagers are gonna have naturally a higher AMH rate. But um but I have like most of the younger women that I've done, it's been like late teens where they've been cycling since they were young. And it's never become regular. They have all the sequelae. We haven't found any other reason, like that conversation has never become regular. and they have benefited from it. But I think it's a rarer population. Now, I've definitely also had like women in their 20s and 30s. Yeah, again, pregnancy isn't in the cards for me right now, but I just want to cycle without having to take all these medicines, or I'm not cycling and I'm taking all these medicines and I just want to have a cycle. And so that's another group of women that are candidates for it. You don't have to be
Yeah.
trying to achieve pregnancy.
Yeah. Yeah. And that makes sense. Cause ultimately, whether it's for a teenager or whether it's for a woman who's suffering from infertility, it's to restore health. Like ultimately
Right.
that's what we're trying to do. Oh, I say we, you.
No,
This is what you're
that's
trying
the
to do.
goal. Yeah.
Yeah.
No, I
Yeah.
mean that is well, that's what we're trying to do in all of it, right? Is we're just trying to
Right.
restore people to health and cause normal function. And so then that's the beauty of PCOS. I heard Dr. Hemphill once, Dr. Christine Hemphill, she's one of the NaPro surgeons. I think she's in Texas right now. And
Mm.
she was just like, just kind of offhandedly, she's like, yeah, this is the closest thing we get to remission of PCOS. Like this is a
Wow.
syndrome that affects you for your whole life. And this is the closest we can get to just causing it to go into remission. And it's interesting because what we didn't talk about is there are still some things that you have to watch in women who struggle with PCOS, even post wedge resection. And there's still some open questions out there. Like one of the things that we know about PCOS is that if we influence how somebody's body handles sugar, handles glucose, we can often help them ovulate better. And it has to do with, again, the function of the liver. And if the liver's handling glucose better, then it will also influence particular proteins and hormones and cause you to ovulate better. So this is why you often see women placed on metformin, which is a diabetes medication. And in fact, that was widely used for a really long time. And it's still, I mean, before it became like a try to get pregnant or take birth control, a lot of women ended up on metformin actually. And now it's starting to actually come back in, like, especially if a woman who suffers from PCOS sees an endocrinologist, they often come away on metformin rather than on birth control, which is really interesting to
That's
me.
great. Yeah.
And so, we use other supplements, myoinositol, berberine, Vitex works in a slightly different way. But cinnamon, like all these things that are shown to help you manage prediabetes and insulin resistance also help you ovulate better when you have PCOS. Well, the question becomes like if you do, so we know the wedge resection can help with certain things. Like if you have high androgen levels, your androgens will drop. So a lot of the acne stuff, you won't stop making new hair growth. Problem like the hairs that have already converted will stay dark hairs, and so they have to be permanently destroyed. Or you have to keep removing them, but there's not going to be any new conversion of hairs because that's what's driven by the male type hormones. Ovulation tends to become a lot more regular. And then, so all of those things are fairly dependable results of the
Mm.
PCOS, of the wedge resection rather. What's really has data going in both directions is whether or not we affect your insulin resistance or your tendency toward it. Every woman who has PCOS, whether they carry extra weight or don't carry extra weight, whether they have a family history of diabetes or not, every woman who carries a diagnosis of PCOS has a higher lifetime risk of developing diabetes. And whether or not we influence that by the wedge resection, there are actually studies that go both ways. Some that say,
Mm.
yes, the wedge resection improves it. Some that say, no, it actually worsens it. And so it's still something that we have to monitor pretty closely and make sure that like we're managing as best as possible with diet and not necessarily the supplements, but just like watching over the course of time.
Yeah. So what is for a typical patient that you've been working with, they decide to go through with the surgery, what is the typical of what you will see? What will they see? I mean, I think I remember you saying something to the extent of like 75 to 90% of women that have irregular cycles
Yeah.
before have regular after. Can you explain a little bit about the hair growth? You said some of it might stay, but some of it might
Yeah. Well,
not.
so
Can you
let's
just
start with
explain
that.
that a little bit?
So
Yeah.
hair growth, okay, when you have high male type hormone levels, what it does is it affects the follicles themselves and it turns them into follicles that grow instead of that like downy hair that we kind of grow elsewhere on our face. It turns them into follicles that grow what we call terminal hair. Those are like the thicker, darker hairs that we notice. And so once a follicle has been made a terminal hair follicle, it doesn't convert back. And so women who struggle with this, um, will like those follicles until they like die, which is pretty, it takes a really long time. Um, they will always have to deal with some extra hair. What it does prevent is new. So if you have it destroyed by either laser hair removal or electrolysis, then it won't be an issue anymore. But you won't have any new growth. So that's one of the challenges. Is like, and we have to talk about that with women. It's like, yeah, you'll notice that you're like the hair won't be as thick because you're not making all these new follicles, and some follicles are dying off all the time. But like, I don't know, I'm in my 40s and I had the Cushing's disease right in my 20s, and I still have like, a lot of the sequelae of that, even 7 kids later. So it's something that
Yeah.
they'll have to deal with or have permanently removed for a long time.
Hmm.
um and then what was the other question? Oh, the ovulation
This,
rates.
yep,
So
yep.
classically, so it's hard because you don't have a lot of more recent data on this. I was actually talking to Dr. Dwayne. We probably need to publish like here are wedge resection results in women who are having it done robotically because there's not a lot of data on that. It was well established as a very effective surgery when it was done a lot in the 80s and 90s. Um, and so all the data are from back then. And Dr. Hildreth, he had a lot of things that he needed to study. And so he was like, well, the data on this are well established. We're not going to repeat these studies. But we've noticed, anywhere from 75 to 90% of women who don't ovulate on their own will start ovulating more regularly with a wedge resection. Um, it generally does make women who are ovulating, but it very irregularly, it almost always will help them ovulate more regularly. And even in that set of women who don't ovulate regularly post wedge, because that's still 10 to 25% of women who aren't ovulating regularly, they do end up having much more sensitive ovaries. So these are often women who nothing could make them ovulate, like any medication you give them, there was nothing that was going to make them ovulate. And then like I've had a couple women where it's like, okay, I'm not ovulating super regularly, but then they start their myo-inositol back up and they take it once a day and then they're back in regular ovulation. Or I have a patient who recently achieved pregnancy where she had pretty regular cycles, and then she was like they got a little more irregular and we didn't know, we were kind of working that up, and then she was trying to achieve pregnancy. We started on letrozole, and where we had never been able to get her to ovulate with letrozole before, she took a very small dose and then she was able to achieve pregnancy. So even in the women, so the hope is that most, and this is what we observe in most women, is that they generally start cycling fairly regularly, fairly quickly after surgery. It's not usually like 6 months down the road. It's usually like within the first few cycles. Um, but some women, like even if they don't, they do have a lot of these benefits that come with it. So a lot of women will see like really regular cycles fairly quickly on afterward.
That's
One of the
awesome.
things that we face and that we are kind of trying to deal with is women with PCOS. Like you've probably heard that women have a high estrogen to progesterone ratio, right? They're
Yeah.
not ovulating
Mm-hmm.
regularly, and they're not necessarily ovulating normally when they do ovulate. So they're
Mm.
not making the right amounts of progesterone. A lot of times they have really high estrogen levels, either because they're not releasing an egg at all or because their progesterone is not as high as it should be.
Mm-hmm.
And so, like chronically, women with PCOS are seeing like really high levels of estrogen all the time. And one of the things that we are trying to work on and just figure out like how do we make this less common. But sometimes when you do a wedge resection, all of a sudden your body goes from seeing a lot of estrogen to not seeing a normal amount of estrogen, and like your cervical mucus receptors can be a little bit not quite used to that. So some women will have a like pretty limited mucus right after because they're like, okay, I went from tons of estrogen to normal
Right.
estrogen and my mucus receptors are used to seeing tons of estrogen to work. And so then we have to work on helping with mucus enhancement and things like that.
Okay. So that doesn't all the time just kind of correct itself over time. So it does sometimes need more intervention after that.
It's real hit or miss, but it's not usually a short-term correction, like maybe
Okay.
over years. but not in the first 3 months, 6 months after surgery.
Okay, I
Yeah.
see. Yeah, it sounds to me it's just this is the best, or from what you said earlier, this is the best way to put PCOS in remission, but it's not
Mhm.
like, from what I'm hearing, it's not the end all be all cure. Like there's still
I mean, there's just things
things.
you
I
have to
mean, what
think
would you
about,
say? Yeah, yeah, yeah.
like I think
Mm-hmm.
there are definitely women who are like, this is the best thing that ever happened to me.
Mm,
We want to make sure that when going into surgery that you're going to be one of those women, or not, I
yeah,
mean, or that you're definitely going to see a benefit.
yeah.
And so that's something that we're just, working on identifying
Mm-hmm.
those women and honestly, like we have conversations, like that's the point, there's things that we can discuss that where somebody can say, okay, like I understand that there's this risk, or like I have a patient who it was kind of a weird picture. And I was like, I don't know that you would like you have these big ovaries, but you're not fitting in all the PCOS boxes.
Mm-hmm.
And she was like, well, I understand the risks if this is not. I said we could try the surgery; it would be reasonable. She said, and I said these are the things that could happen afterward. All the stuff. And then she ended up achieving pregnancy a few times after that. So that was like, and she had never achieved pregnancy before, and we'd like never been able to make it work with anything else. And we had already taken out endo and stuff, like we'd done all the other stuff. And so like just the wedge resection. So it's not off the table, but it's just a conversation that has to happen between the surgeon and the woman who's suffering from PCOS to make
Yeah.
sure, like, yeah, we don't want to throw you into a new problem.
Mm-hmm. And I imagine that this is very similar with any surgery. I mean,
Oh yeah,
I just had
yeah.
back surgery a few months ago, and it's the same conversation, right? There's always risks with opening
Hmm.
yourself up, and no matter how big the the incision is, right?
Hmm.
It's always a conversation with
Hmm.
the patient and the surgeon, I feel like. So I don't think that that's any different than a normal or any other surgery would be. The last thing I
Right.
wanted to ask you is, because I feel like talking about what to see after the surgery happens. You hit on the high testosterone, the hair growth, and what you might see after that. You hit on, your ovulation becoming more regular. I want to touch on the third thing that, because way at the beginning, you had said that there were three things that we're looking for to even diagnose PCOS. That was high
Right.
androgens, irregular cycle or irregular ovulation, and then polycystic ovaries. So what do the ovaries tend to start looking like after post-surgery with those follicles? I mean, do they just kind of atrophy? Like,
No, because
what
well,
does that
that's the
look
thing is
like?
that we take out the extra ovary and the rest of the ovary remains intact.
Okay.
So what you end up seeing is an ovary that still has a polycystic morphology, meaning it's like the follicles tend to still be kind of peripheralized around the outside, but the antral follicle count is more normal and the size of the ovary is normal. So they look like little polycystic ovaries, just not big polycystic ovaries. And so because they don't change their shape necessarily, and we're not removing, like they're not dying off or anything like that. We're just taking that out. We're taking out the extra. And so yeah, so they tend to just look like, you know, little polycystic ovaries, but they function
Okay.
better.
Yeah.
Um, yeah, and ovulation can, and I didn't mention this, but most of the surgeons like who do this surgery, especially those in the SPS, like the ones who did the fellowship, most of us use a long absorbing suture because we find that it works a little bit better for making that like really nice tight closure that minimizes scarring. And so you have that suture in your ovary for about 3 months before it fully disappears. And so the problem is that if you develop your follicle, it's like, right, the follicle just develops. This is actually, okay, I don't know if you've probably explained this to your viewers before, or they understand this, but I find that there's a lot of women who
Say
don't
it.
understand
Yeah.
this.
Yeah.
Like
Yeah. Please.
ovarian tissue is all seen as the same by your body. So you don't alternate ovaries when you ovulate. It's not like right ovary, then left ovary, then right ovary.
Which you
It's,
very lovingly corrected me.
oh, I didn't know we talked about that. But that's a
We
super
did.
common thing. And it totally makes sense, right? It was like, okay, we did this side. Now we're going to do this side. Now we're going to do this side. Like, that like it makes total sense. But, but the ovarian tissue, like your brain's talking to your ovaries when you're trying to ovulate, and it just talks to all the tissue. And so that somewhere in your ovary, there's going to be a follicle that grows a little bit larger than all of its friends. and a little bit faster, and it produces a little more estrogen that shuts down all the other follicles that are trying to grow. And so it can happen anywhere in the ovary. Like it can happen at the top or the bottom or around the edge. So if you've got this big like suture line in your ovary and the follicle kind of develops like right here, then a lot of times what happens is that like there's sutures there and they might kind of impede the development of the follicle, and then it might have trouble rupturing, or it might cause you a lot of pain because it's stretching out all that suture. And so for the first 3 months after surgery, if it's painful to ovulate, it's okay. Like we tell people, like you might have some weird ovulations, it might be kind of painful, and that's okay. It's not going to last that way for more than 3 months, or more than like 3 cycles usually. And that's an important thing that we have to, just prepare people for.
Yeah, for sure. Do you ever give your patients, okay, wait 3 months or however long to try to achieve pregnancy because of those sutures, or no, you're
No,
shaking
because
your
then
head?
if you do, like, think about it, if you don't ovulate, then you're not going to get pregnant. Like if you don't actually release the egg, then you're just not going to achieve pregnancy. But generally, if you do ovulate, it's a fairly healthy ovulation. And the hormones actually correct fairly quickly. And so we usually clear our patients, like we start testing hormones, and I'll start looking at like post-ovulatory hormones immediately after surgery, especially in women who are open to achieving. If it's just like somebody who wants to cycle regularly, then we just say, okay, hang out for 3 months and then let's see where we are. But if it's somebody who's trying to achieve pregnancy, then we move right back into trying to achieve immediately. Because most of them, when they had their wedge resection, also had endometriosis resected. And that, like the time right after surgery is the best time when you're like all your inflammation is decreasing and everything's good. And so we usually have them jump right in to trying to achieve. And then we test people with 7 hormones. And if they're a little off, then we look at ultrasounds to see if they're actually releasing eggs and stuff like that. So there's a lot of things that we do, but we do jump right back in after surgery.
Okay, yeah. I know I said last thing the last time, but this
It's
is the
okay.
last thing. So when somebody's asked me about this surgery, just as in very lay terms, this is kind of how I've been explaining it, but I want to hear what your thoughts are on this very layman's terms of it. So the idea being, most women with PCOS, or some women at least, have those enlarged ovaries. So with the ovarian wedge resection, you're going in, taking a pizza slice, or, out a wedge out of the ovary, shrinking that ovary. And the idea being estrogen is coming from your ovary. And so if you're producing too much estrogen, as you mentioned, a lot of women who have PCOS have high estrogen. If you're shrinking the ovary, then you're reducing the amount of estrogen that is being produced. Am I right in saying that? Or
Yes,
how
and
would you
but also
add?
testosterone. Like that's a
Okay.
big part of it too. And that's part of like what actually happens in the ovary. There's a hormone that converts testosterone to estrogen. It's called aromatase. And so yeah, like so you're reducing both. And there's things that like that's definitely like a, a, a reasonable explanation. And it's kind of funny though, because we do and we don't understand how it works. Like it's really funny where it's like that's certainly part of it, but there's part of it that has to do with removing extra antral follicles. It's not purely hormonal. And so it's just kind of like a strange thing where it's like, yeah, we've just observed that this works. It's like and that's certainly a big part of it. Like you reduce estrogen, you reduce testosterone. There's a better conversation with the liver, and that stops stimulating the ovary as much. Similarly, a lot of women will ask, can a polycystic ovary grow back, or can it become polycystic again? We have not found that to be the case. Generally speaking, if somebody has a wedge resection and then they are not see, like we look at the ovaries and they look big and polycystic again, usually it's because we were a little ginger and we didn't want to over wedge, and we kind of under wedged, because it's a really challenging, like, make sure you get it right. Like take enough to make it work, but don't take so much that they don't ovulate because their follicle count's too low. So generally it doesn't grow back. But yeah, but it's like it's in the same way that like removing endometriosis improves fertility, but we're actually only now figuring out why. Like, why does it improve fertility?
Yeah.
That's a whole nother conversation. But some of these things we've just observed and we're like, yeah, we know that this works. Who does
Yeah.
it work for is the most important thing to figure out. Are you in that group, and should we do this?
Yeah. Yeah. And I
Yeah.
think that's an interesting point too of, does it come back? Would you potentially have to do the surgery again? And just so for the listeners, before we started recording, I was telling Dr. Kreller, I just came back from a conference by Facts About Fertility. Amazing conference. It's going to be next year at the end of April in Washington, D.C. for any of those that are interested in it. But there was a talk given by Dr. Helen. Can you say her last name for
Gyogu.
me? Thank you.
Yeah, Dr. Ajiogo.
And
She's in Illinois.
okay, yeah. And she gave a phenomenal talk on the ovarian wedge resection. And I asked her that exact question of, do you see, have you ever done a second ovarian wedge resection on someone? And the way that she responded, she goes, well, the night is still young, but no, I have not seen that to be a need. So, which is extremely hopeful and amazing. So, Dr. Kreller, thank you so much for being on the podcast, for sharing your wisdom. I really, really appreciate it.
You're welcome. Thanks for having me. I appreciate it.
Thanks.